All right, fantastic. Well, it's been an incredible day of information and sharing. And we want to now really talk about another important issue within the Black communities worldwide, and certainly in Birmingham. There's a prevalence of kidney disease in the Black community, and that's the name of this additional panel. And we have Dr. Kate Bramham, a clinical senior lecturer and the honorary consultant nephrologist for the Department of Women and Children's Health, School of Life Course Sciences, Faculty of Life Course Sciences and Medicine at King's College in London. Dr. Kate is passionate about reducing health inequities in kidney disease and has a special interest in diagnosing and managing kidney disease affecting Black communities. We want to welcome Dr. Kate and thank you so very, very much for joining the Black Health Matters International Summit and sharing your extremely important knowledge with us today. Dr. Kate, welcome. We look forward to hearing the news and information you have about this prominent kidney disease in the Black community. Thank you so very much.
Thank you very much for that kind introduction. I want to thank the organisers for the opportunity to talk to you. I have to confess I have got a lot of experience talking at conferences and to different students, but I've never done a presentation like this before. So I hope I get it right. I guess one of the joys of webinars is that you can just always turn the sound off or even switch me off if I'm not getting it quite to your needs. But anyway, here we go. I'll share my slides now and hopefully that will work. There we go. So I'm going to talk about kidney disease in Black communities. I'm going to talk about why we think there's kidney disease in Black communities and about the causes. But I thought I would also take the opportunity to give you a bit of an overview about what the kidneys do. The reason why I've become interested in this field, for my historic background, is actually looking after women who have kidney disease who become pregnant. But 5 years ago, I started as a consultant at King's College Hospital, and that's a hospital in southeast London where there's a very diverse ethnic community. And I look after the patients that are just starting on dialysis. And I was already aware of it, I suppose, but it became increasingly clear to me that there were a lot of young Black people that were starting dialysis, and we didn't really understand why their kidneys had failed. And I felt so strongly about how this was impacting on their future, their lives, their families' lives, their communities' experience. That I felt that it was important that I started to do a bit more. And I'd like to sort of share with you a little bit about my current knowledge, and maybe in the chat afterwards we can kind of explore what we think needs to be done to improve the situation. So as I said, I'm going to take the liberty, if that's all right, to talk a little bit about what the kidneys do first of all, and the symptoms of kidney disease, how we currently test for kidney disease and some of the current treatments for advanced kidney disease available. And then I'm going to touch on the topic that I think we're really kind of most interested in, and why Black communities are more affected. So just to backtrack, if I may, that the kidneys, I'm passionate about kidneys because I think they're just absolutely incredible in terms of what such tiny organs can deliver. And even people who have got one kidney and survive, they're tiny, but they do so much. They're in your back and just kind of below the ribs there, as you can see on this picture. And they're composed of millions of blood vessels. And these millions of blood vessels take blood from the circulation system through the kidney and through these filters here. I'm not sure if you can see my arrow. And that is the processing unit of the kidney, the nephron, as we call it. And it's no surprise that because the kidneys are so full of blood vessels, that they are very commonly affected by other diseases that affect the blood vessels. So diabetes and hypertension, which we know are the conditions that can cause other blood vessel problems that lead to heart attacks and strokes. And I'll talk about that in a little bit more detail shortly. So we know that the kidneys, they produce urine, and the urine drains through the ureters into the bladder here and then out through the urethra. And what's quite incredible, for just such tiny organs, they take up 1/5 of the blood supply from the heart at any one time. And so over 1 litre of blood enters both kidneys every minute, and 1,700 litres of blood is cleaned every day in a single individual. So overall, we have about 7 or 8 litres of blood, and that blood is cleaned 400 times a day. So they are working so hard, these little organs, through tiny, tiny blood vessels. And the cleaning units, the nephrons that process the blood once it's been filtered through to make sure that the content of the urine is correct, that all the toxins are in there and all the good things have been removed and put back into the bloodstream. That if we were to put these tiny, tiny little tubes, these nephron tubes together, from one person, they would stretch over 16 kilometers. And because I'm from the UK and you're in the US, that means nearly 10 miles. And so what do the kidneys actually do? They have a very important role in terms of removing toxins from the blood. And obviously, if the toxins aren't removed and they build up, that can lead to symptoms. The other key thing the kidneys do, as you probably expect, is they control the amount of water that's in the body. And they do that so carefully that you can imagine if you have an enormous glass of water, that the kidneys can process that and regulate exactly how much water you've got in your body. Concentrations of things are really important to equilibrate, to maintain what we call the homeostasis, the balance in the body of all sorts of different processes. They also balance very carefully the different electrolytes, the chemicals in the body and the minerals in the body, so potassium, sodium, calcium, magnesium, you name it, the kidneys tightly regulate that so that everything is very perfectly balanced to allow the other body's activities to continue as normal. The other relationship, which I think probably a lot of people are aware of, are that the kidneys are very tightly involved in blood pressure control, and that's to do with their relationship between retaining sodium, which contributes to higher blood pressure, and water, which also contributes to blood pressure. But they also produce a hormone called renin, which causes the blood vessels to constrict, and that increases blood pressure as well. And one of the frustrating and paradoxical things about kidney disease is that when the kidneys start to struggle, they start to put out more renin. And this causes the blood pressure to get higher, and it causes the kidneys to become damaged. And it's a vicious circle of increasing renin, increasing blood pressure, increasing kidney damage. And that's one of the reasons why one of our mainstays of treatment for kidney disease is to control blood pressure, to protect the kidneys and reduce the renin production. The other thing that not many people know about is the kidneys actually also do other things. They detect when the body's oxygen capacity is reduced, and we know that red blood cells carry oxygen around the body. They sense that, and when the red blood cell count is starting to fall, there's substance called erythropoietin, which carries the oxygen, the hemoglobin, which carries the oxygen around the body. When the hemoglobin starts to fall, the kidneys produce a different hormone into the circulation called erythropoietin that acts on the bone marrow to tell it to produce more red blood cells. So when people get kidney disease and the erythropoietin production starts to reduce, then they start to become anemic, which causes tiredness. The kidneys are also really important in maintaining healthy bones. So they do a lot more than just sit in your back and produce urine. They activate vitamin D, which we know is a really important substance for helping our body to absorb calcium. And obviously, if there isn't enough calcium in the body, we get weak bones, we get weak teeth. And what happens is the body, in order to maintain calcium levels, if we're not able to absorb it from the gut because we haven't got activated vitamin D produced by the kidney, that the body starts to use up the calcium stores that it already has and make the bones weaker, remove the calcium from the bones. So there are lots of things that can happen when the kidneys don't work so well. The toxins, the salts in the blood, the acid in the blood, the kidneys get rid of acid as well, and these things all build up. But interestingly, not many people with kidney disease actually die from kidney disease. They die from complications to do with their blood vessels. When the kidneys don't when the kidneys don't work so well, we think that these toxins and also the conditions that affect the kidney, that they cause damage to the other blood vessels in the body. So people actually with kidney disease tend to die from heart attacks and strokes rather than kidney failure itself. And I've said the bones can become weaker and the red blood cell count can drop because of the failed production of erythropoietin. This is a really long list of kidney problems, symptoms that people can get. And then a lot of them are kind of very non-specific, and you probably never guessed that the kidneys were causing them. But just to really highlight, this is sorry, I've missed a D there, but this is at very advanced stages of kidney disease. When you start to get these problems, people can cope very, very well with relatively little kidney function. But when the toxins are really building up, when the kidneys are kind of 20%, only working at 20% or less, they start to get these problems. As I said, one of the problems in terms of looking after people with kidney disease is that we often don't pick it up until it's quite advanced, because people just feel perfectly well, even though their kidney function can be very much reduced. We know that when 90% of the kidney function is lost, that people do have a much higher risk of dying, unfortunately, due to not only kidney failure, but heart attacks and strokes that I've highlighted. Some of the key treatments that we can use for patients who've got kidney failure, as I say, people tend not to die from kidney failure if they've got access to these treatments, is hemodialysis and peritoneal dialysis. And these are approaches that we use to artificially clean the blood and regulate the fluid and the minerals and salts in the blood artificially. And this is what I was describing, that people have to come to the hospital for usually 4 hours, 3 times a week. And it's very, very burdensome, plus the time to travel, plus the time to wait. And this provides enough kidney function to keep people alive, but it doesn't give people the energy or the independence that normal kidney function would provide. Peritoneal dialysis is a little bit different. It can be done at home, and it's utilizing the lining of the abdominal cavity to actually perform the function of the kidneys, which is quite incredible. And people have fluid that drains in, usually at night, delivered by a machine, and then the lining of the peritoneal, this abdominal cavity, actually acts as the kidney, as I say, and the waste is drained out. But it's really, really hard to maintain a good quality of life, very hard to retain employment. And this is the thing that has really struck me with a lot of young people having to start dialysis, that their lives have dramatically changed. And one thing that's kind of relatively unknown is that actually kidney disease, kidney failure is associated with a much higher death rate than many other conditions, including some cancers that have actually spread. So this, to my mind, we need to raise awareness. We need to get more funding to do more research to make this situation better, because yes, we can treat cancer with chemotherapy, but dialysis keeps on going until people don't survive. One other very successful treatment, of course, though, is a kidney transplant. And just out of interest, the kidney transplant is a new kidney that's not put where the old kidneys are. It's actually put into the groin. because it's easier to access there, it's easier for the surgeons to put it in, and we use the blood vessels actually supplying the legs and to plumb the new kidney in so that it can get a good blood supply. And I know that this is a problem in the States, but it's also a big problem in the UK, that people from, sorry, this is an old slide, and obviously we're no longer using this categorization of ethnic minority groups, but people from ethnic minority groups in the UK and in the US have to wait a lot longer for organs, and much less likely to get on the waiting list even, and they wait a lot longer once they are on a waiting list for kidney transplants. So just moving back to how kidney disease is actually found. So it's very rare that somebody comes in and says, oh, I think I've got kidney problems. It's usually picked up due to tests for other reasons. So if a patient is attending a hospital or a clinic for a different reason, maybe to have their blood pressure checked, or because they've got a liver problem, for example, we might just pick it up on blood tests. Or it might be that they're having their urine tested for another reason, to check for infection maybe, and we're picking up some protein that needs to be checked out. Very occasionally we pick up kidney disease on having a scan, and people might find that there's one kidney's a lot smaller than the other, for example, or there are some abnormalities in the kidney disease, like lots of cysts, which are fluid-filled pockets that can damage the structure of the kidneys and cause kidney problems. And this would usually only be found if somebody was perhaps having an ultrasound for a different reason, like when they're pregnant, for example, and then we look into that more closely. So in order to detect kidney disease, we identify that it's there, and then we look very closely for a cause, but the gatekeeper tests, if you like, are to do a blood test and to measure something called serum creatinine, which I'll talk about a little bit more in some detail, and also to do a urine test to actually identify if there's any protein in the urine and whether or not there's any blood in the urine that might be an indicator that there's some leaking from within the kidney. So we measure something called creatinine, and this is a substance that is global in terms of assessing for kidney disease. There are some problems with it. The joy of it is that it's very cheap to measure and everybody's very familiar with it, and it's been used for nearly over 100 years now as a marker of kidney disease, but actually it's not produced by the kidneys at all, and it's really sort of fortuitous, I guess, in a way that it was discovered as a marker of kidney disease. The levels of creatinine are different in different individuals, and again I'll talk about that again in a little bit more detail, but you can see here in the UK we use these different units, but I know in the US that you use these sorts of units to describe kidney disease. Now, you may want to switch off at this point, and I try not to make it too complicated, but creatinine, as I said, isn't made by the kidneys at all. A lot of other tests that we do are actually made by the organ. For example, liver tests, liver function tests are created by the liver, and we measure them and they go up when there's problems with the liver. But actually, creatinine starts out as a substance called creatine, which is made by the liver. And that's converted in muscle to an activated form called phosphocreatine, which is energy. And this is naturally broken down about 1% to 2% per day into the substance called creatinine. And that goes through in the bloodstream to the kidneys, and it's freely filtered through the kidneys and is excreted and eliminated from the body in the urine. So you can imagine if the kidneys aren't working so well, that the creatinine, isn't removed from the body quite so effectively, so it starts to rise. And so with time, with somebody with kidney disease, as it gets worse, it never looks quite like this, but anyway, just as an example, the creatinine will start to rise. And so what we would like to do as kidney specialists is to find people when they've got creatinine levels down here so that we can give some treatment and protect the kidneys. But quite often what happens is when the creatinine is a lot higher, when people start to get symptoms, we identify the kidney problem. But there are problems with creatinine itself as a marker of kidney function. Yes, it does start to go up as the kidneys start to fail, but the amount of creatinine that people's bodies produce naturally is actually quite different. And definitely those people who've got a lot more muscle, who are able to do this conversion process, produce a lot more creatinine. So people that are bodybuilders have got higher creatinines, even though their kidneys function perfectly well. So there can be some confusion when you see a high creatinine about whether or not it's to do with the kidneys not getting rid of it, or whether or not the muscle is producing more of it. Now, it's important for us to be able to, it's pretty obvious, isn't it, that we need to be able to use a marker to be able to detect kidney disease. But there are problems if we get it wrong. And obviously, with people with more advanced kidney disease, if we don't get it right, we might think that their kidney function is around about here, but actually they're heading more closely towards kidney failure, and we need to start to get them listed for kidney transplants, or we need to prepare them for dialysis. But also, if we say that the threshold for a diagnosis of kidney disease is having kidney function less than 60. And this is the marker that we use. It's called glomerular filtration rate, that we kind of convert the creatinine into as a percentage of kidney function. But obviously, if we're missing people, if we're not diagnosing kidney disease, then we miss the opportunity to give them protective medication against heart attacks and stroke, which are the big problems for people with kidney disease. And in addition, we may prescribe drugs inappropriately. We may underprescribe, or we may overprescribe, because we know that the kidneys are playing a very important role in getting rid of medication. So obviously, if we're thinking that kidney function is better than it actually is, we might give somebody too much of a drug, and it might build up in their system and cause problems. Obviously, the downside of over-diagnosing kidney disease is it may be that we get, again, the drug dosing wrong. We may label someone as having kidney disease when they haven't got kidney disease. That may cause anxiety, and also potentially problems with getting health insurance as well. So we've developed these equations that help us to understand these creatinine levels, which take out some of the complexity of the muscle production and the liver production of this substance, creatinine. And we know that people, as they get older, start to produce, with the creatinine levels go up. We know that men produce more creatinine than women. And historically, we've also thought that people who are Black produce more creatinine. That there are various equations that have been developed in the US based on populations, including some with smaller numbers of people of African ancestry. This included 8% of people of African Americans. This equation, the CKD equation, which is now recommended to be used globally, included over 30% of African Americans. But we're now starting to kind of wonder whether or not it's actually appropriate to be using these equations. Certainly in the UK, we've got different patterns of heritage, and obviously with the horrific slave trade has contributed to the number of people of African ancestry in the US. There are different patterns of migration as well in the UK. And we did a piece of work looking at how to measure kidney function accurately in our UK population. And what we're recommended to do at the moment is to multiply kidney function to take into account this potential for increased muscle production of creatinine. We're supposed to increase our percentage of kidney function by this factor, this correction factor, by 1.159. So we increase, that basically equates to increasing anybody who we think is Black or self-reports as being Black to have 16% higher kidney function than they would if they weren't Black. But actually the work that we did suggests that we shouldn't be doing that. We should be only increasing it by 2%. We've been doing quite a lot of work and communication in the UK, and certainly we've decided at my unit to stop using this correction factor, because we feel that we're overestimating people's kidney function. We're not being able to provide the care for them with kidney disease that we should be. And certainly this work, I won't bore you with all these numbers, but this work has been replicated in lots of African countries as well. And using this multiplier means that the actual estimate of kidney function, the percentage of kidney function on the basis of the blood test, the creatinine blood test, means that we're not as accurate as we perhaps could be. And then obviously there's this enormous problem to do with race and making healthcare-based decisions on the basis of race, which we all know is a social construct. And who's making the decision about who's Black, who's white, who's of mixed ethnicity? So I think for many reasons, this alone is a reason not to be using this multiplier factor for estimating kidney function. And you'll be very pleased to hear that actually this is changing globally. And I'm just so sorry that it's taken us so long to recognise the importance of this. But there's a task force in the US that are working very hard to gather more information about how better to measure kidney function in different ethnicities. But they've already recommended that we shouldn't be using it, and certainly in the US it shouldn't be used. And we need to consider the individual in front of us based on our assumptions about their muscle mass and their age and their sex. Obviously, I have to say, it's harder now that we're moving practice into more of a virtual care world. I'm sure it's the same with the COVID pandemic, that certainly in the UK, we're having to do a lot more work remotely, and that sort of adds further complexities. But I think it's best practice at the moment not to be making any changes on the basis of race for estimates of kidney function. And now moving on to kidney function as a bigger problem and where it is in the Black community. It's known as the silent killer, as I've described, because it doesn't present until late. People don't have complications, and it's estimated to actually be one of the leading causes of global mortality in the next few decades, unless we do something about it. The biggest causes of kidney disease, particularly in the US, are diabetes and high blood pressure. But there are also genetic conditions which we think are likely to be contributing, and other problems that where the kidneys become blocked, for example, and that causes damage, or whether or not they're inflammatory conditions, particularly lupus, which can also damage the kidneys. But we also know that there are lots of health inequalities in terms of who gets better care for their kidneys and who progresses more rapidly. And certainly we know that lower socioeconomic groups are more likely to firstly develop kidney disease and also to have more rapid progression and to die younger, unfortunately. We know, interestingly, that women are more likely to be diagnosed with kidney disease, but men are more likely to start dialysis, and we don't really understand the reasons for that. It might be that women are more likely to engage with their healthcare, perhaps. And perhaps unsurprisingly, that older people are less likely to get kidney transplants. But we do know, as I've highlighted already, that people from ethnic minorities are much less likely to get kidney transplant, but they're also more likely to get kidney failure and more aggressive kidney failure. In our unit, Black patients are more present with needing to start dialysis when they're 10 years younger, which is just, to my mind, is absolutely mind-blowing. And I can't think of another condition that has that inequality that's quite so profound. And it's probably even more profound in the US, and the proportion of people that have got kidney failure, or what we say end-stage kidney disease, so requiring dialysis or a kidney transplant when the kidney function is less than 15%, is much higher in people of African ancestry or African Americans in the US. You can see that 13% of the US population are reported to be Black, but 35% of the people who've got end-stage kidney disease are Black. So there's something wrong, to my mind, going on here. Now, one thing that's been recently discovered in the last decade, which is hopefully going to make an impact, is this genetic change in a gene called Apolipoprotein L1. Now, like sickle cell disease, there are benefits in having this, this genetic change, genetic mutation as we call it, because it appears to protect against sleeping sickness. So this is the tsetse fly, and this is the trypanosomiasis, which is the condition, the sleeping sickness bug. But if people have got this gene, then actually they're protected because they can form a channel in the surface of this bug and cause it to explode. It sounds a bit sinister, doesn't it? But that has protected people over centuries, and that's why there's more of this gene in the population than we would perhaps normally anticipate. And so, as I said, one abnormal gene protects against sleeping sickness. But what has recently been discovered is that if you've got two of these abnormal genes, like sickle cell, where one gene protects against malaria, but two abnormal genes causes sickle cell disease, 2 of these ApoL1 abnormal genes means that you're up to 17 times more likely to get kidney problems, particular types of kidney problems as well. And so just to outline that in a bit more detail, it's likely that people inherit 1 gene from their father and 1 from their mother. So their parents are fine and they don't have any kidney problems. But depending on the number of abnormal genes that you inherit, you might become affected if you've got 2. And these ApoL1 genes are very, very prevalent. Up to 34% of the population have 1 gene in West Africa. And obviously because of the patterns of slave trade from West Africa, that's why a lot of African Americans and people from the Caribbean also carry this gene, where it may not be relevant in terms of protecting against sleeping sickness anymore, but it's been kept in those populations. And more recently, it's been proposed that approximately 4 in 10 African Americans who are on dialysis have this condition. It potentially causes more kidney problems as well in people who've also got diabetes, but certainly 70% of people without diabetes who've got kidney problems is thought to be due to ApoL1 disease. But one thing that we don't yet understand is that there are more people who have this genetic change that don't have kidney disease than do have kidney disease. So there's something that must happen on that journey to cause people to develop kidney problems. So the good news is that we're now moving forward in I hope more aggressively to test people, to identify people that are at risk. And there are some new treatments that are being developed that we need to develop more rapidly, to my mind, to actually protect people with early signs of kidney disease to enter that rapid journey of deterioration and ending up on dialysis. The good news is that a lot of other kidney diseases are preventable, and possibly the ApoL1 disease could be slowed by general healthy lifestyle measures. So keeping a low weight, exercising can help protect the kidneys in the same way that it does help protect the blood vessels from heart attacks and strokes. Keeping well hydrated is also important. It protects the kidneys from acute insults and acute kidney injury. We know that when the kidneys aren't working so well, they very stupidly retain a lot of salt, which means that puts the blood pressure up, which damages the kidneys. So actually reducing the amount of salt in the diet can be very, very helpful to protect the kidneys. And as I've said already, preventing blood pressure, controlling blood pressure, pushing blood pressure down as far as we possibly can with the medications that we've got can definitely help protect the kidneys. And that is the biggest treatment that we have at the moment to protect the kidneys. Eating healthily, leafy greens, beetroot is very important for keeping the blood vessels healthy. And interestingly, people that are happier are less likely to get kidney problems as well. So I don't unfortunately have a recipe for staying happy, but certainly people that are depressed are more likely to get kidney problems too. Thank you very, very much for listening to me. I hope that there are a few people that are still awake and listening out there. And I'm really happy to take any questions if there are any. I'm going to stop screen sharing now and have a look at the chat. Can't see anything in the chat at the moment, but what I'll perhaps do is just wait a few more minutes and see if there are any more questions that come in. I apologise, I do appear to have run way over time. I'm so sorry. Okay. Well, thank you ever so much for inviting me. I've really enjoyed talking, and I wish you all the best and I hope you enjoy the rest of the day. Thank you very much.